Assalamu alaikum everyone. Welcome to Pelvic Anatomy. In the beginning, we are going to talk about the important bony features of the pelvis. Of course, you must be already knowing that the pelvis is composed of 4 bones, right? 2 pelvic bones, one here and the second over here, the sacrum, and finally the coccyx. Right, these 4 bones articulate with one another to form the bony pelvis. Is that right? The pelvis itself is divided into 2 sections. The pelvic cavity is divided into 2 sections. There is a line which we call the linea terminalis. A line we call linea. I'm gonna have to use a thinner line. It's the thinnest, called linea terminalis. Right, it's a sharp edge of bone beginning anteriorly from here. This is over here. We have the pubic bones, isn't it? Right, from the superior edge of the pubic bone. Right, there's a line which is going to continue into the ilium, and then this sharp edge of bone ends right about here, right at the above the sacroiliac joint, and then we continue on top of the sacrum, and then the sacral promontory, and then the same from the other side. This forms the boundaries of the pelvic inlet. Boundaries of pelvic inlet. We have symphysis pubis anteriorly, superior aspect of pubic bones, then along the ilium, and then along the top of the sacrum to form a continuous ring, right, which is called pelvic inlet. This divides the pelvis into 2 compartments. A compartment above it, which is called the false pelvis, and a compartment below it, which is called the true pelvis, true pelvic cavity. The false pelvis is actually a part of the abdominal cavity, right? It's a part of the abdominal cavity. All right, let's start talking about the bones one by one. First, let's start with the pelvic bone. Let's remove all of the surrounding bones so we can have a clear view of the pelvic bone itself, right? One pelvic bone. And here we have it. This is like anterior view, right? And here is a medial view. And from here we can see a lateral view. And that's a posterior view. Now the pelvic bone is composed of 3 sections. Anteriorly here we have the pubis. It's oriented in the antero-inferior plane, as you can see. And on the back and below, postero-inferior plane, we have the ischium. Many people call it ischium. I used to call it ischium. But now I came to realize that the correct pronunciation is actually ischium. And superiorly, we have the biggest part of it. It's the ilium. Right, let's talk about the pubis first. So the pubis, that's pubis. Is that right? It is composed, it's better to see it from a lateral view to see all the parts. So we have a part which is anteriorly oriented, right over here, which is called the body of the pubis. This section is called body of pubis. And from the body, 2 rami emerges. A ramus moving superiorly and a ramus moving inferiorly. Right? The one that is moving superiorly is referred to as the superior pubic ramus. We know that, right? Superior pubic ramus. And the one inferiorly is called inferior pubic ramus. No fun in that. The superior pubic ramus moves to meet two bones. It moves to meet two bones. It will move to meet the ilium over here at this junction, and also the ischium. Let me show you. Of course, we go here to the acetabular socket to see it better. This is pubis. As you can see, pubis meets the other two bones, the ilium and the ischium, at the area of the acetabular socket, the acetabulum, where the head of the femur articulates. All right? There are more features related to the superior pubic ramus. If we move on top, right, we see that it has a very sharp superior edge. It has a very sharp superior edge, which is called pecten pubis. This is called pecten pubis. Now, this pecten pubis is very important area because it's the site of attachment for the pectineal ligament or Astley Cooper ligament, the one that we talked about in abdomen, if you guys remember that, right? Let me show you how that works. So let's move here. I'm gonna draw the inguinal ligament. It starts from here, right, anterior superior spine, and it ends over here at the pubic tubercle. Now, from the medial end of the inguinal ligament, right, fibers come out like this, which is called lacunar ligament, to attach to the superior part of the pubis, and then tongue-like continuation from that along the pecten pubis is called pectineal ligament. Right, it forms the posterior border of the femoral ring. Is that right? And it also, pecten pubis is a part of the linea terminalis, right? It's the antero-inferior part of the linea terminalis that I told you about. On the superior aspect of the body of the pubis, if we move up like that, we see two important features, right? One feature is a raised crest of bone here. This is like a bridge or raised bridge of bone. This is called pubic crests. Pubic crest. And then it ends as an elevated bulb of bone, which is called pubic tubercle. Pubic tubercle. Is that right? And we know that the pubic tubercle is the site of attachment of the inguinal ligament. And the pubic crest, right, it forms the base of the external inguinal ring and the attachment site for the conjoint tendon. Do you remember in abdomen, right? Conjoint tendon. Okay. Of course, the body of pubis meets the other pubic bone here at the pubic symphysis, right? All right. Now, the inferior pubic ramus, there isn't much to talk about it. It just moves down and meets the ramus of the ischium to form the ischiopubic ramus. Ischiopubic ramus. Okay. That's what we need to know about the pubis. Very simple. One last note about the pubis. You know this hole in the pelvis? Here, this big huge gap. This is called obturator foramen. Right? Obturator. Foramen. It is like closed with a sheet of connective tissue membrane. I'm gonna show you this membrane here. Right? When we add the ligaments and everything, as you can see, it's closed off with a sheet, except for this tiny gap here. Right? This very tiny gap, which is called the obturator canal, through which the obturator nerves and vessels pass. This part of the superior pubic ramus, right, which forms the upper margin of the obturator canal, is called obturator groove. It's called obturator groove. Okay, so it's simple. Things are very simple. Again, I can also show you the pectineal ligament here again. As you can see here, this is the inguinal ligament, and this is the lacunar ligament, and the continuation here is the pectineal pectineal ligament. Here's the lacunar ligament, and here is pectineal ligaments down here. All right. The femoral vein should be here, and this portion here is the femoral ring. So in front is inguinal ligament, posteriorly is pectineal ligament, medially is lacunar, and laterally is the femoral vein. Very simplistic, right? Very simple. So we talked about pubis in detail. Now let us move to the ischium, right? Let's see the ischium now into detail. Ischium has a lot of important features. This is femur, we need to remove it, and then we need to go, as I told you, lateral view so that we can see all parts of the ischium, most parts of the ischium. So this is ischium, the right one, right? It has a body, right? A big body. And from the body, it ends inferiorly as like here. This portion is called ischial tuberosity. Very important in the lower limb, right? Because the hamstring group of muscles, the semitendinosus, semimembranosus, and long head of biceps femoris, they all originate from this portion. There's also the ischial bursa. It's the site where we sit, the bone on top of which we sit. The lower part of the ischium is like L shape, right? Lower part is called ischial ramus, or ramus of ischium, which meets the inferior pubic ramus here to form ischiopubic ramus, right? Which is gonna form the majority of the borders of the obturator canal, obturator foramen, sorry. Is that right? Because obturator foramen, if you see, it's bordered by ischium and over here by the pubis, right? Ischium on the back and pubis on the front, the superior and inferior pubic rami front, and ischium on the back. There's a very important feature of the ischium, but that feature we see it here. We need to see it from posterolateral view. This one, there's a projection from the body of the ischium. Very sharp projection here, called ischial spine. All right? There's a very important relationship about the ischial spine. It's used a lot in clinic. First, you know, when women get pregnant and they want to deliver a baby, the head of the baby, the lower limit of the head of the baby, we can know its position during passage through the birth canal in the second stage of labor in relation to the level of the ischial spines. Let me show you what does that mean. We need to go on the front, right? This is the pelvic cavity here. And back here, these two are the ischial spines. We're just gonna connect a transverse plane from them, right? And that's the head of the baby, suppose, right? We need to make them a smiley, beautiful baby because, yeah, upside down, of course. That is cephalic presentation. This is occipito-posterior. It's not very good. Anyway, so the head of the baby, when the head of the baby, the top of the head of the baby is exactly level with the transverse plane of the ischial spines, we call it station 0. If it's below it 1 cm, station +1, station +2. Above it, -1, -2. So we can use it to monitor the descent of the baby. That's one important thing about the ischial spine. The more important thing in the exam to remember about the ischial spines is I want to show you something. I want to bring a ligament here into view. Okay? And I want to bring the nerves into view. Yep. So let's go at the back. Let's go at the back. And you know this ligament, we're gonna remove this one. This ligament, I'm gonna remove it all. I'm gonna remove this one. I'm interested about this one, this ligament. This is called sacrospinous, sacrospinous ligament, because it comes from the front of the sacrum, right? And it attaches to the spine of the ischium. So we call it sacrospinous, okay, ligament. There's a very important nerve, right? There's a very important nerve that loops around this area. Do you see this nerve that I'm highlighting? The pudendal nerve. The pudendal nerve. Now, pudendal nerve is the nerve of the perineum, right? It supplies the muscles of the perineum. It supplies sensation to the perineum. It's the nerve of the perineum. So there's a lot of operations that goes on with the perineum. We need to block the perineum so we can work on it. One way to do it is to inject local anesthetic solution near the ischial spine, right? Because ischial spine is here. That's ischial spine. This is the ligament. And the nerve loops around this area. It loops around it. So from the vagina, right? We're going to go out here. From the vagina, from below, a finger is inserted. And then we can feel, it's a palpable landmark. The ischial spine over here is a palpable landmark. And then we inject the local anesthetic near the ischial spine because we know the pudendal nerve moves over here. That's a common question in the exam, right? When you want to do pudendal nerve block, what is the site of injection? What landmark you will use for the injection? It is what? Again, the ischial spine. Okay. So, we had a lot of talk about the important bony anatomy. Now, that's it about the ischium. Those are the important things about the ischium. Now, I'm going to talk about the ileum now. There's a lot to see in the ileum. Now, ileum is the most superior bone, right? And it has a wing, right? This wing, this expansile wing of the ileum. This wing, we call it simply wing of ileum. And it has two surfaces. This surface that we see here is the inner surface. The inner surface. And this inner surface, we call it iliac fossa, right? And it is the origin of the iliacus muscle, if you remember that from abdomen. And the back surface is called the gluteal surface, because the gluteus maximus, minimus, medius, they originate from here. That's in the lower limb. We don't need to confuse ourselves with it now. But important thing that the top portion here is very thickened, as you can see. This is called the iliac crests. This is called iliac crest. It is thickened such as that a lot of muscular attachments happen here, right? Like the transversus abdominis, the external oblique, the internal oblique. Many muscles attach here. Along the anterior edge of it is the anterior superior iliac spine, right? It is the site of attachment for inguinal ligament and the origin of sartorius muscle in the lower limb. And then just under it there's another projection or spine. It's also anterior but below it, so we call it anterior inferior iliac spine. It is the site of attachment for a muscle called rectus femoris. Rectus femoris muscle. It's a muscle of the lower limb, anterior compartment of thigh, rectus femoris. And also a ligament which is called iliofemoral ligament, a very important ligament of hip joint. It's actually maybe the strongest ligament in the entire body. All right? So we talked about these anterior features. On the back, if we move all the way to the back, we see similar spines. We see similar spines. There is the posterior superior iliac spine, and then the posterior inferior iliac spine. Just under the posterior inferior iliac spine, the bone angles sharply forwards to form a notch. Form a notch called greater sciatic notch. Those are going to become so important for us later. This is called greater sciatic notch. And then there's the spine of the ischium. Under the spine of the ischium, there is a little less pronounced notch, right? It's called lesser sciatic notch. These notches become foramina when they are enclosed by ligaments. Let's see that now. Let's bring the ligaments into view. And as you can see, there are two important ligaments. This one, sacrotuberous ligament, because it comes from the sacrum and it actually inserts into the tuberosity of the ischium. And then the other one that I already told you about, which is sacrospinous ligament. These two ligaments converts the notches into foramina. So there will be greater sciatic notch above the sacrospinous ligament and lesser sciatic notch below the sacrospinous ligament. These notches we'll take in detail later, right? But I just want you to know what they are, where they are, just a simple idea. Final important thing about the ilium that I want you to know is this. The crest itself, if we check the crest from above, like this, the crest of ilium near the anterior superior iliac spine here, it kind of have a lump. It is thickened like a tongue-like extension outside, which is called tuberculum of iliac crests. That's referred to as tuberculum of iliac crest. Now, this tuberculum of iliac crest is the site where the iliotibial band attach. It can be used as site for that is bone marrow biopsy from the iliac crest. But why it's important in the exam? Why it's important in the exam? Let's go to anterior view. Let's move a little bit up. And I just want to bring the vessels. Okay, I want to bring the big vessels into view to show you something so important. All right. So we have the vessels here, right? What I want you to know, we have here, that's the aorta, right? And near it, to the right of it, is the inferior vena cava, IVC. Now, if you take a horizontal plane which cuts through the tuberculum of iliac crests on either sides, it will be here, right? That's a plane which cuts through the tuberculum of iliac crests on either side. This plane is simply called intertubercular plane. This plane, intertubercular plane, is level with the fifth lumbar vertebra, the body of fifth lumbar vertebra, L5. At this very same plane, the right and left common iliac veins join together to form the inferior vena cava. Common question in exam. There's another important plane, which is just on top of it. This plane is the very top portion, of the iliac crests. It sits on the highest points in the iliac crests. It is just above the intertubercular plane. Because this plane sits on top of the highest points of iliac crests, we call it supracrestal plane. We call it supracrestal plane. Now, this plane, the supracrestal plane, is at level of L4. It's above L5, right? It's at level of L4. It's the site where the aorta bifurcates. You can remember it. L4, aorta bifurcates. into right and left common iliac arteries. It's also the same plane that we use to administer a lumbar puncture. Let me show you from behind. Right? This is what vertebra? This is the fifth lumbar vertebra. This is what vertebra? This is the fourth lumbar vertebra. Let's take the supracrystal plane. It cuts through L4, right? So it takes us to L4. So we can use this plane as site of administration of lumbar puncture. Lumbar puncture in adults should be, also in children is the same level, supracrystal blade. It should be around L4, either between L3 and L4 here, or between L4 and L5 here, okay? That's another very important plane to be aware of. All right, okay. Now I want to talk about some important joints which brings the pelvis together. Let's remove the connective tissues and the vessels. Let's go back to the dry bone. Now, the three parts of the pelvic bone, the ilium, pubis, and ischium, they are initially in the embryo. They are initially three separate bones, but then they fuse. They fuse in the acetabulum, okay, and it becomes complete fusion at around the age of 16 years. Around the age of 16 years. Initially, there's a cartilage between them, which is called the triradiate cartilage, because as you can see, it's like Mercedes, right? Triradiate, inverted Mercedes. Triradiate cartilage. Okay. So that's simply how the three portions join together. They join here. Ilium, ischium, pubis, they join here. If we come out the front, we see how the two pubic bones join together in front at the symphysis pubis. And on the back, they are joined with the sacrum, right? At the sacroiliac joints. Now these joints are huge joints, the sacroiliac joints. Very massive joints. They commonly become ossified with age. These are also very common site for involvement in ankylosing spondylitis, right? Sacroiliitis is a common manifestation of ankylosing spondylitis. These massive joints are actually synovial joints. Let me show you how these two bones meet. For that purpose, I just want to remove the sacrum and show you the inner surface here. Let's remove this vertebra also. And this is the surface of the ilium that meets the sacrum. It can be divided into two portions. An antero-inferior portion that is roughly L-shaped. This is where the hyaline cartilage sits, right? It's the articular cartilage, articular surface. Above and behind that is another region, but that's like roughened. It's not for articulation, it's actually for ligament, right? Called sacroiliac ligaments, which reinforces the sacroiliac joints. On the sacrum, guys, there's a complementary surface. Let's bring the sacrum back. And now let's remove the ilium now to see it. There's a complementary surface as well. There's L-shaped region here. And there's a roughened area over here. So it can complement. Now because of the L-shaped articulation, it's L with L, right? L with L. The joint is interlocked. There's no movement at all, like very little movement that is permissible, almost no movement. So it is tightly interlocked. Okay. What makes this joint very strong now? Let's see that. This joint is so strong because there's a lot of huge ligaments supporting it, collectively called sacroiliac ligaments. Let's see that. Let's bring connective tissue back. There's some ligaments that I'll remove for now, okay? There's, as you can see, this huge ligament here highlighted. is in front of the joint. It just spans from the sacrum to the ilium. It's called anterior sacroiliac ligament. It's a strong ligament. If we move from the back, there's another similar one on the back, right, which comes from sacrum to the ilium, which is simply called posterior sacroiliac ligament. It's also strong. But you know who's the strongest one? Let's remove the ligaments. This one is the strongest one. It is underneath or deep to the posterior sacroiliac ligament. It's called the interosseous sacroiliac ligament. The interosseous sacroiliac ligament. It is between the anterior and posterior, sandwiched in between. It is the strongest of the three and the most important of the three. Disruption of this ligament can lead to dislocations in this joint, in massive trauma, for example, or in huge pelvic fractures where the posterior ring is disrupted, whatever. Okay, so that's what makes this joint very strong. As you can see, huge ligaments supporting it. Remember, the most important is the interosseous ligament. So now we know how the pelvic bones form a ring. Posteriorly sacroiliac joints and anteriorly pubic symphysis, and along the acetabular sockets the three bones fuse at the triradiate cartilage. Alright, I want to now talk about the sacrum. Let's see that. Let's remove the ligaments or connective tissue and let's see the sacrum. Here's the sacrum. I'm just gonna isolate it on its own. That's our beautiful bone sacrum. And this sacrum is actually used to be 5 separate vertebrae. But then they fused together to form this triangular or wedge-shaped bone, one mass of bone. If you see laterally, the sacrum actually have a concave surface anteriorly and convex posteriorly, right? Below it meets this tiny bone, coccyx, and above it meets L5, and laterally it meets ilium. Anteriorly, it has 5 openings, as you can see. 4 pairs of openings, which are called anterior sacral foramina for the emergence of anterior sacral nerves, rami. There are similar ones on the back, right? Called posterior sacral foramina for the posterior rami. On top, we have a hole or opening, right? Hole or opening for the sacral canal. It's the continuation of the vertebral canal, and it ends down the bottom with a hole, which is called sacral hiatus, right? Now, there's a small detail, not that important, but this is the coccyx. It's formed of like 4 or 5 fused coccygeal vertebrae. It have horns that project upward called cornu. There's a similar descending horns from the sacrum, and that's how the sacro-coccygeal junction is formed. 2 horns meeting each other. Oh, that's it. Now, when you look at the sacrum, on top it have these facets. There's a facet over here, another facet over here. These facets are designed to articulate with L5 vertebra. Not only that, there's also this surface. This surface for the intervertebral disc between L5 and S1, the first sacral vertebra. So it means what? If they ask you in the exam, how many joints are there between L5 and the sacrum? There is a joint created here, that's 1. A joint created here, that's 2. And finally a joint created here, that's 3. So there are totally 3 joints between L5 and sacrum. Of course, this joint is just the intervertebral disc, but these 2 joints are called zygapophyseal joints. Zygapophyseal joints. Funny name. But these are joints between the superior and inferior facets. It's similar throughout the spine as we talked in spine lecture, right? Let's bring L5 here into view. Let's bring all the bones back. Yep, that's L5. Let's go at the back and see the zygapophyseal joint. As you can see, this is L5. From it emerging the inferior articular facet. There's a complementary facet on the sacrum, and a joint is formed here. These joints collectively are called lumbosacral junction. Lumbosacral junction. What reinforces that? Let's go and see the ligaments which reinforces that. There are basically two important ligaments which reinforces them. Okay? There's a ligament here, highlighted here, called iliolumbar ligament. Iliolumbar ligament. This ligament typically originates from the transverse process of L5 and moves to attach to the ilium. So it's indirectly reinforcing because the ilium is attached to the sacrum, right? So it's indirectly stabilizing the lumbosacral junction. There's yet another ligament. For us to see it, we have to remove the iliolumbar. Here, this tiny other ligament, which also comes from the transverse process of L5, but it attaches to the superior aspect of sacrum. It's called lumbosacral ligament. Right, so two important ligaments, in addition, of course, to the other surrounding ligaments, like the anterior longitudinal ligament here, right? The other ligaments on the back of the spine that reinforces most of the rest of the spine. Anyway, we know them from the spine lecture. But special ligaments for this region is the iliolumbar and iliosacral ligaments. All right, so I think we've covered everything regarding the bony anatomy of the pelvis. Next, we move to the orientation of the pelvis and differences between male and female pelvis.
Now, the pelvis is actually oriented in the standing position or the anatomical
position, such as that the pelvic inlet. Right, let's revise the borders of the pelvic inlet again in a more accurate way. As we said, it begins anteriorly at the pubic symphysis, over here, at the pubic symphysis anteriorly, and then it moves along the pubic crests, then pecten pubis, which is the sharp edge over here. This is called pecten pubis. And then this line, which traverses the ilium, to the just above the sacroiliac joint, then this portion of the sacrum, which is called ala of sacrum, then along the anterior margin of the first sacral vertebra, which is called promontory, then along the other ala of sacrum, and again along this line, similar line over here, right? So here, starting here at pubic crest, as pubic symphysis, then pubic crests, then pecten pubis, then this line on the ilium actually has a name called ariquate line, and then ala of sacrum, then the promontory of sacrum, All of this is called linea terminalis, is that right? These are the parts of it. I mean, starting here, linea terminalis strictly means ariquate line, pecten pubis, and pubic crests. Okay? Now, this inlet is actually in the standing position faces forwards, as you can see. In the standing position, it faces forwards. And if you take a horizontal line in the standing position, vertical line, this vertical line, as you can see, these are the anterior superior iliac spines, and these are the pubic tubercles. They are at the same vertical plane. All right, it may be surprising for some people, but it is. It is the same vertical plane. and the two inferior pubic rami almost faces straight downwards, right? As you can see, if we move here, the front of the pubis, we need to go down to see the two inferior pubic rami, here and here. By the way, they form arch between them, commonly called pubic arch. Pubic arch. All right. This is the orientation of the pelvis. Of course, male and female pelvis differ a lot. And it mainly has to do with the passage of the baby through the birth canal. First of all, the inlet in the female is much larger and it is circular. This is a male pelvis and the inlet is more or less like a heart shape. But in the female, it's actually more circular. Why it is so? Because in the female, this forward projection from the sacrum, the sacral promontory, is more blunt. Okay, it doesn't project as much as in the males into the pelvic inlet. So that's one difference. The pelvic inlet in the women is circular and in the men it's heart-shaped. Why it's so? It's mainly because of the main reason is that in the female the promontory is less prominent, and also in the female the ala of the sacrum here and here are much more broader, okay, compared to the male. That's one difference. The second difference has to do with the pubic arches. This is male pelvis. Actually, the angle of the pubic arch in the male is less. It's about 50 to 60 degrees in the males. Whereas in the females, it's wider. The angle is larger. It is actually much larger, 80 to 85 in the females. Okay, again, this will broaden the pelvic outlet and ease the passage of the baby through the birth canal. Additional important difference is the ischial spines. In the male, as you can see, they project way in. Their projection medially is more. But in the female, it doesn't project a lot medially compared to the male. So those are the differences. Again, let's repeat. Pelvic inlet in women is circular. In men, it's heart-shaped. Why? Because in women, the promontory is less prominent and the ali are broader. The pubic angle, right, of the pubic arch is about 50 to 60 in the men and 80 to 85 in the women. The ischial spines are more prominent, and in the women, they generally do not project as far medially into the pelvic cavity. Okay? Okay. Next, I want to talk about the pelvic walls. Okay, the pelvic walls. Pelvic walls, for that purpose, we need to talk, of course, pelvic walls means of the true pelvis, below the level of the pelvic inlet. I mean this wall, right? And it has ligaments and muscles. It's formed by ligaments and muscles. Let's talk about the ligaments. We've already talked about them briefly, but now in more detail. Okay? So, the posterolateral wall of the pelvis is formed by several ligaments. Okay? The first ligament here, which I've already told you about, the sacrospinous ligament. This ligament is triangular in shape, right? The base of the triangle is attached to the sacrum, the front of the sacrum. And the apex of the triangle is attached to the ischial spine. Right? That's one ligament. There's a ligament which is superficial to it. Which is this one. It is behind it. The sacrotuberous ligament. To see it better, let's go from the back and see the full extent of this ligament. This is posterolateral view. I don't want those ligaments. Let's remove them. This is the sacrotuberous ligament. Itself is also triangular. Actually, in this 3D animation, it is not that accurate because it begins from here and then along the sacrum and the coccyx, and then like this. Do you see? All of that, it spans all of that. It begins here at the superior posterior iliac spine, and then along this ridge of the ilium, and also the inferior posterior iliac spine, along the back of the sacrum, and the dorsolateral surface of the coccyx. This is a wide range of origin, you can say. It's big area of attachment. Posterior inferior iliac spine, posterior superior iliac spine, sacrum, coccyx. And then it moves like that, right, superficial to the sacrospinous, and attaches to the ischial tuberosity. Now, these two ligaments have important functions. The first function, it stabilizes the sacrum on the pelvic bone. Specifically, they like this in the exam, it prevents the upward tilt of the sacrum. It prevents the sacrum from moving like this. These two ligaments fixes the sacrum here and here, right? It fixes the sacrum to the ischium at the spine and the tuberosity. So the sacrum is unable to tilt upwards. They specifically ask about that in the exam. And secondly, we already know it converts the greater and lesser sciatic notches into foramina. The greater sciatic notch is above the level of the sacrospinous ligament, and the lesser is below, right? So it's simple. Additional ligaments, or let's say membranes, is actually here. Do you see this one? The obturator membrane, which covers the obturator foramen, right? We've already talked about them. It's attached to the margins of the bones of the obturator foramen. It has the canal on top. Okay, so we talked about sacrospinous ligament and sacrotuberous ligament. Now let's talk about the muscles of the pelvic wall. So let's bring them into view. I'm going to remove some of the unnecessary muscles so we could just cremaster, iliopsoas, iliacus. We just want to focus on the muscles we have at hand here. Okay, so I'm not going to talk about the floor muscles. I just want to talk about the side wall muscles. Okay. First muscle that I would like to talk about is very special muscle. It's this one highlighted here, which is called the obturator internus. It forms the anterolateral wall of the pelvis, right? I'm just going to remove some of the floor muscles so that we can see the full extent of the obturator internus. As you can see, obturator internus comes to originate from the deep surface of the obturator membrane, right? Which is underneath. Is that right? If you remove this muscle, you can see the membrane underneath it. But in fact, it does not only originate from the deep surface of the obturator membrane, but also from the bones that make up the margin of the obturator membrane. Then it is covered by its own layer of fascia called obturator fascia. This muscle is very sneaky. The fibers travel posteriorly, okay? And then, if you remember, this is which ligament? Sacrotuberous. And this is which ligament over here? Sacrospinous. Okay? This muscle, I will remove it for now. I will remove this muscle for now, called coccygeus. Now it is much clearer. Do you see what's going on? The obturator internus muscle, it moves posteriorly. This is what ligament again? Sacrospinous. And behind it is sacrotuberous. So what is this hole? Lesser sciatic foramen. Is that right? This is lesser sciatic foramen. Now, this muscle makes a 90-degree turn. To see where it comes out, we're going to move from the back. I'm going to move from the back and there's a group of muscles with it. I'm going to remove them and just focus on obturator internus. This is obturator internus tendon. It is emerging from the lesser sciatic foramen here, makes a 90-degree turn and moves posterior to this joint, hip joint, and then comes to attach to the femur. At this particular point in the femur, this is called greater trochanter of femur, specifically the medial aspect of the greater trochanter of femur. Okay, medial aspect, there's a notch for it, medial aspect here. So it's very sneaky muscle, right? Again, let's repeat. It comes to originate from inside here, anterolateral pelvic wall from the obturator membrane associated bones, moves posteriorly through the lesser sciatic notch, makes a 90-degree turn underneath the ischial spine, and it will emerge from the back over here. Do you see? Emerging from the back, and then passes behind the hip joint, and it finally inserts on the greater trochanter of femur. This obturator internus, right, is supplied by its own little nerve, which is called simply nerve to obturator internus. It's from L5 and S1. And the actions of this muscle forms, it have a structural action, right, or function. It forms part of the pelvic wall, especially anterolaterally. But function-wise, it's simply, you can think about it, it's so easy, right? This is posterior view. When the muscle contracts, the line of pull is here with this arrow. So the femur, it tends to rotate outwards because we are looking from behind now. So it rotates in this direction, which is outwards. So lateral rotation, especially when the hip joint is extended in the position. But when the hip joint is flexed, so let's see lateral view. Imagine with me that this femur moves into this flexed position. If the obturator internus muscle tugs on it in this direction, actually it will tilt out. The femur tilts out. That is abduction. So what is the action of obturator internus? Lateral rotation of extended hip, abduction of flexed hip. Okay, you can imagine it. It's simple to imagine. So this is one muscle out of the way, obturator internus. Now I want to talk about another muscle, which is also so special and so important in the exam. I'm going to talk about it now on the left side. Okay, I'm talking about this one, guys, which is piriformis muscle. Piriformis. Now, the piriformis muscle originates from the front of the sacrum. Okay, here. Actually, from the bridges of bone, it's not so accurate in the animation, but it actually comes from the bridges of bone that is between the anterior sacral foramina. Here, here, and here. From the bridges of bone between them. Then forms a muscle, little muscle belly. This muscle belly actually, guys, it moves like that through the greater sciatic foramen, because remember, this is the ischial spine, and now we're talking about above the ischial spine, and this is the sacrospinous ligament behind. So it is moving through the greater sciatic notch, that is foramen, right? Where is it going? You can see where it is going even from here, right? I'm gonna go through the back, but it comes like that. Here it is peeking out. It's moved posterior superior to hip joint. Let's go through the back. It's better to see it from the back. Here it is, emerging as a massive, majestic muscle from the greater sciatic foramen and insert on top of the greater trochanter, above the insertion point of obturator internus. Now this muscle makes a very important division or subdivision. Let's remove all of the other muscles because I want to show you something so important. Let's remove the piriformis, okay? And now we can see the full extent of the greater sciatic notch, isn't it? And foramen. Now let's bring it back. Let's bring the muscle back. Now, when the muscle is back, it will actually divide. It will divide the greater sciatic notch into two compartments. A compartment below, called inferior compartment, and compartment above, called superior compartment. They love this so much in the exam. They ask about what are the structures that are passing through the inferior compartment and what are the structures that are passing through the superior compartment. To make it easy for you, all of the structures that pass through the greater sciatic foramen pass below the piriformis, except superior gluteal nerve and vessels. Superior gluteal nerve and vessels, but everything else pass below it. We're gonna come to the details of that, don't worry. Piriformis, so we know origin and insertion. The innervation, it have its own special nerves, right? From originating from S1 and S2, so it's supplied by sacral nerves, S1 and S2. And action is just like obturator internus because it is similar geometry of the muscle, right? It can externally rotate the femur. Lateral rotation, when it pulls or tugs like that, it will externally rotate the femur if the hip joint is extended, and if the hip joint is flexed, it will abduct the femur. So it is same action as obturator internus. Okay, very well. So we talked about the muscles that form the walls. Later I will tell you about the floor muscles. But for now, I want to talk about in detail about the apertures of the pelvis and what kind of structures that pass through these apertures. First, one simple one we already talked about. There is an aperture here, which is the obturator canal, right? Obturator canal is bordered by obturator membrane and obturator internus muscle from inside and externus from outside. There's another one called obturator externus from outside. And the superior pubic ramus, particularly the obturator groove above. What passes through it? Nerve-wise, there is a nerve called obturator nerve, right? So I'm going to bring the vessels and nerves into this region. These are vessels and nerves. That's enough. So as you can see, let's hide some of the structures over here to see things better, right? So also removing this one. All right. So as we can see, this one here is the obturator artery. It's a branch of the internal iliac artery, specifically the anterior division. And here we have the right obturator, that is vein, right? It accompanies the artery. And here is the nerve, obturator nerve. So those are the structures which are passing through the obturator canal. Where they're going to the medial compartment of the thigh. Okay, they are headed towards that medial compartment of the thigh. Now let's go to the sciatic notches and foramina, greater and lesser sciatic notch. So let's talk about greater sciatic notch first. The greater sciatic notch, as I told you, it has two compartments, superior and inferior compartment. Let's focus on the simple one, superior compartment. So from the superior compartment, as you can see, as I told you, there are superior gluteal vessels and nerves. Right, here it is. This is the superior gluteal nerve with it's a branch of the sacral plexus, right? And these are the vessels, superior gluteal artery and vein. So we'll just remove them to simplify the picture. Okay. Now there's a whole lot of things going on below it, below the muscle, below the piriformis. Let's hide some of the muscles here on the back and see first, of course, structure that is striking is this huge, biggest nerve in the body, right? The sciatic nerve. So sciatic nerve, it is variable. They love this in the exam so much. It is variable. It may emerge through the muscle or even above the muscle in rare instances, but in most of the people it emerges below the piriformis. In addition to the sciatic nerve, there's a group of other nerves. Now just know them by name. We will talk about them in detail later. The posterior cutaneous nerve of the thigh, or called posterior femoral cutaneous nerve, which is this one, posterior cutaneous nerve of thigh. It supplies the back of the thigh and the posterior aspect of scrotum. Nerves, little nerves that go into the muscles in this region, including nerve to quadratus femoris, right? The inferior gluteal nerve and the internal pudendal vessels and nerves. They are all passing with their accompanying veins. They are passing below. But again, as I tell you, I will go into detail of all the neurovascular structures that are passing through. The lesser sciatic notch, on the other hand, what are the structures that are passing through here? So, for instance, we've already talked about one structure, right? Which is the tendon of the obturator internus. Remember that? Right? The tendon of obturator internus. Let's bring it back. Here it is. Tendon of obturator internus muscle pass through the lesser sciatic notch. Passing through the lesser sciatic notch as well, you know, the pudendal nerves and vessels, they emerge from the greater sciatic notch below piriformis, but then loops under the sacrospinous ligament and re-enters the area through the lesser sciatic notch. Okay, so they emerge out, then they emerge in. You get me? So it is considered a structure that passes through both the inferior compartment of greater sciatic notch and the lesser sciatic notch, simply because they loop to enter the perineum. So those are the important apertures, right? Again, let's repeat. We have lesser sciatic notch. What passes through there? Pudendal nerve and internal pudendal vessels, and also the nerve that supplies obturator internus, by the way, nerve to obturator internus. And obturator internus itself tendon passes through this region. Clear? No problem? Okay. So those are the structures. Moving on, I want to discuss about the pelvic outlet. We talked about pelvic inlet, but now let's talk about the outlet. We need to remove all the muscles. We just need to leave the dry bone only. Okay, to see pelvic outlet, let's move down below like this and go like that. We need to add the ligaments. Here it is. So pelvic outlet is like roughly diamond in shape. Okay, it is diamond in shape, right? The anterior part of that, it's all ligaments and bone, okay, but anterior part of it is predominantly bone. What borders them? It's the ischiopubic rami here, right? Remember, this is pubis, this is ischial tuberosity. So this is ischiopubic rami, anterolaterally. Immediately anteriorly is the pubic symphysis, right? That's immediately in front. So that's the anterior portion. The posterior portion is mainly ligaments, right? Which is specifically the sacrotuberous ligaments. So we have sacrotuberous ligaments here and here. And posteriorly in the midline, we have the coccyx. So those are the borders. Remember, the borders of the pelvic outlet. Pelvic outlet is totally closed, almost, by the pelvic floor. But these are the borders. It's diamond in shape. Anteriorly, we have mainly bone, right? Anterolaterally is the ischiopubic rami. Immediately in front is pubic symphysis. On the back, posterolaterally, is the sacrotuberous ligaments as they descend. Can you imagine it? As they descend like that. Let's go back like this. Do you see? As they descend down, they make this. So as they descend down, they make some of the boundary, posterolaterally specifically. And immediately posteriorly, we have the coccyx over here. The coccyx is immediately posterior. Fine. On the lateral there is immediately lateral sides is the ischial tuberosities. One huge lumps of bones. This pelvic outlet, the anterior portion of which is closed. The anterior portion is closed by a membrane which is called perineal membrane. This membrane, it's not shown on the diagram, but it extends from the ischial tuberosities. And like this, it has a tiny hole in front. I'll tell you about it later. And it covers all of that region. The perineal membrane is a tough membrane, right? It does not extend posteriorly. Posteriorly, there's no perineal membrane. And it has a free posterior border. It has a free posterior border. In the middle of that free posterior border, there is a condensation of connective tissue referred to as the perineal body. Right? Have some functions, again, we'll come to it later. So I have the perineal body right in the posterior part. Okay, now I have to tell you a concept. Okay, for that concept to be clear, I want to go and put in some muscles here. Okay, let's put in some muscles. Hide the ones that we don't want. All right. This is like iliopsoas and iliacus. Let's remove the femurs as well. Remove obturator externus. And go down. Go down below. These are some of the muscles in the perineum. I'll tell you about it. Now I want to make something clear. Do you see these are the floor muscles, the pelvic floor muscles? We still didn't get to them. Here it is, right? Pelvic floor muscles. These are called like puborectalis, etc. Underneath it, underneath the plane of the floor muscles, this region is called perineum. This region is called perineum, right? So, if you take it from this view, and like that, right? Like this. This is the plane of the muscle. This is the inferior limit. So all of that is perineum. Okay. Now I told you about the membrane which is covering this. Membrane is covering this region. Do you know the area or the space between the membrane and the floor muscles is called deep perineal pouch. Deep perineal pouch. And the area external to the membrane is called superficial perineal pouch. Okay, these divisions are so essential to understand for perfect understanding. So let me draw it like here in simple diagram, right? This is the pelvic floor muscle, and this is the perineal membrane. This space or pouch is the deep perineal pouch, and this space is called superficial perineal pouch. They love to ask about the contents of each of them. Again, as I will tell you the details later, but I want it from now early on in the pelvic anatomy, that concept is in your head, okay? It has to be in your head, this concept. Okay? Another important concept. As I told you that there is, when you come back to the pelvic outlet, there is a membrane, perineal membrane is here, right? Covering this region, perineal membrane. Now, if you take a line connecting the ischial two porosities, you will end up dividing the perineum into two triangles. A triangle in front and a triangle on the back. This triangle in front, this first triangle in front, is the area where the urethra passes in the male and the female, and the vagina passes in the female, right? So it's called urogenital triangle. Uro because urethra pass, genital because, you know, the vagina and the female's pass. So urogenital triangle. And the one on the back, the anus passes through here, so it's called anal triangle. Okay, do you understand these divisions? Another concept, that these triangles are not actually in the same plane. If we move laterally in the standing position, it's like this. The anal triangle is oriented almost facing the floor, but the urogenital triangle, but the anal triangle is oriented facing backwards. Do you see? It's not at the same plane at all. That's another thing to keep in mind. All right? Okay, very well. Next, we will move to pelvic floor and talk a little bit about that. The pelvic floor muscles, when we zoom in, are mainly two huge muscles. Okay, mainly two huge muscles. There's a muscle which is over here, extending from this point, guys, and along this line, and then to the back of the pubis, and then the other muscle is over here, originating from this line along this, and then they descend to form something like a bowl. Okay, and then they meet each other along the midline raphe. These two big muscles which descend like a bowl, of course you have to know that they are not horizontal. As you can see, they kind of dangle down. Let's remove the bone over here and just see how these muscles exactly descend. Okay, let's remove these structures. As you can see, they descend downward, something like a bowl or a sheet. You get me? They are not like that. So they meet each other from both sides. And let's get the bone back. Okay, bone is back. These two are collectively called the levator ani. Okay, levator ani muscles. The second muscle of the pelvic floor are these two triangular muscles, referred to as coccygeus. Together they form this bowl-shaped muscular partition between the pelvis and the perineum. Okay? Okay, so let's just go into detail of the levator ani muscles. Okay? These two levator ani muscles from each side, okay, they come to originate from the pelvic side walls. This line of origin begins from the back of the pubis. At this particular point, from the back of the pubis, it's attached firmly there. And then remember this muscle here, which is the obturator internus. And I told you earlier that there's a layer of fascia covering the obturator internus called obturator fascia. Now, the obturator fascia is particularly thickened along this line. And the levator ani originate from this thickened obturator fascia. Okay, so that's the second line of origin. This particular thickening of the obturator fascia from which the muscle originate is called the tendinous arch. In the end and in the back, it originates from the tip of the ischial spine. Okay, from this line of origin, the muscle descend and meet its partner from the opposite side. Now, typically, there is a gap in the muscle or a defect that is located anteriorly, which is a big defect. This defect is U-shaped defect, right? This defect is attached to the underlying perineal membrane. I will tell you about it in a minute. It's U-shaped defect. It's in the anterior region of the levator ani, and this defect is referred to as the urogenital hiatus. Okay, it's called urogenital hiatus. This defect is there for the passage of urogenital structures. In the male, the urethra only. This is the male pelvis, so we only see one hole for the urethra. But also, there is the vagina in the females as well. Now, the sides of the urogenital hiatus, the margin of the muscle at these sides, it merges with the connective tissue of these structures that is passing through it. You get me? So when the urethra pass, the outside walls of the urethra merge with these. When the vagina in the females pass, it merges around it as well. Okay? Now, this particular edge of the muscle in the females act as a sphincter for the vagina. It maintains closure of the vagina. Okay? So, let's see another detail in this muscle, but this detail now is in the back of the muscle. On the back of the muscle, posteriorly, they are attached to the coccyx. Okay? So coccyx is roughly around here. All right? And the muscle behind, as a unit, is attached to the coccyx, and it forms a ligament in the midline. Okay? Forms a tough ligament called anococcygeal body or anococcygeal ligament. Okay? Anococcygeal body or anococcygeal ligament. This ligament anchors the muscle to the front of the coccyx, firmly anchors it to the front of the coccyx. Many textbooks, they divide the levator ani muscle into three main portions, and some textbooks even more. These portions are just parts of the same one-in-one muscle. I mean, it's the same muscle. So here we're looking from above, right, at the levator ani. This is obturator internus. This portion, the medial most portion of the levator ani muscle, is called the puborectalis. As you can see here, it's written, the puborectalis. The puborectalis muscle, the name is very easy. It's self-explanatory. Pupo for pubis, because this muscle originates from the back of the pubic bone. This particular part of the muscle, originates from the back of the pubic bone. Right? And then the muscle passes posteriorly and inferiorly. It descends as it is passing posteriorly. And actually, it meets behind, this is anal opening, surrounded by the anal sphincter. It meets posterior to it, okay, and forms a sling. It forms a sling around the anorectal junction. So let's try to see this in more detail. Let's go and put some of the viscera inside. This is the sigmoid. We're going to remove the sigmoid. So we have, this is the rectum, right? And when we move to the side, we have to remove a lot of structures to reach this. When we move to the side, like this, let's remove the pelvic bone from this perspective, and also all the muscles on the side. I want to reach this particular point. This is the other levator ani muscle. As you can see, the puborectalis muscle. So this is, again, this is rectum. That's too thick of a line. This is rectum. And the rectum, of course, it will become anus. It will become continuous with the anus. This point is called anorectal junction. The puborectalis muscle is this one. Here it is making a sling around, of course, after meeting the opposite side, around the junction of rectum and anus. This creates an angle. This is the long axis of the rectum, long axis of rectum, and this is long axis of anal canal. So there's an angle created between the long axis of the rectum and the long axis of the anal canal. So it means rectum, as it is descending down, and then it enters the sling created by puborectalis, it deflects postero-inferiorly in this direction and continues as anal canal. This is called anorectal angle. Anorectal angle. This angle is so important for continence, to maintain continence. It is like if you have a pipe, right? And water is running through this pipe. As long as the pipe is patent, water will keep coming out. But imagine if you kink the pipe. If you kink the pipe like this, there's an angle, water will have trouble moving out. So it means this anorectal angle is important for continence. This angle is increased, or it becomes tighter, if the puborectalis muscle contract in this. Of course, when it contracts like a sling around the anorectal junction, pulling it forward and making the angle more acute. So it increases the continence. It means puborectalis muscle has not only supportive function for pelvic viscera, but also continence. This is so important in the exam. So it means during defecation, the puborectalis muscle has to relax. It has to relax so that this angle is opened. The rectum and anus become like a straight line. It's straightened, and fecal matter can smoothly pass out. But when it is finished, the puborectalis contract again, and it restores the angle. So remember, for defecation, it has to relax, and for continence, it has to contract. So important in exam, this thing, okay? All right, let's come back to put all the bones back in picture, and let us remove the rectum and everything, okay? So let's go back to our beloved levator ani. So is this first part clear, guys? Right? It's so clear. The puborectalis muscle, part of levator ani. Lateral to it, we have another part. It is called the pubococcygeus. Again, the name is self-explanatory. Pupil for pupus, because it comes also like pupil rectalis from the back of the pupus at this point. And then it travels postero-inferiorly, but now it actually attaches to the front of the coccyx. Of course, the other muscle does the same. So pupil coccygeus for coccyx. Okay, that's the other part. The next part, which is the most lateral and largest part, which is this one. This one is called the iliococcygeus. Iliococcygeus muscle. This is the final and largest part. It originates from the tendinous arch that I told you about, from the thickening of the fascia of obturator internus muscle over here, and also from the ischial spine. It descend downward, so it's coming off of the obturator fascia, and then it descend down. Also the other side descend, and they meet each other behind the anus in a midline raphe. Okay, so if we're gonna have to remove this portion of the muscle, the pupococcygeus, and these two muscles come together at the midline with a raphe that attaches onto the coccyx. So, okay, so this is levator ani muscle. Clear? I think it's so clear. The levator ani muscle as a whole is clear. It's the largest muscle that forms the pelvic floor, right? It has three parts. The medial most is called puporectalis, followed by pupococcygeus, followed by iliococcygeus. Together they're called levator ani. On the back, they're attached to the coccyx, form the anococcygeal body, and anteriorly to the pupus, and anterolaterally to the tendinous arch. Okay, so what is the actions of the levator ani? I think I've explained the majority of them. First of all, it contributes significantly to the pelvic floor, and that supports the pelvic viscera, right? It maintains the anorectal angle and thus is important for continence, especially the puporectalis. And also in the females, it acts like a functional sphincter for the vagina. Not only that, remember, this is the anal sphincter. Anal sphincter all around is surrounded by levator ani. So when levator ani muscle contract, it also compresses the anus from outside. So it acts to reinforce the function of the anal sphincter. This is function-wise. I want to add one thing they like to ask in the exam. During digital rectal examination, of course, you put your finger here. That's your finger inside, right? And when you put your finger inside, roughly after 4 centimeters the way up, roughly 4 centimeters, that's roughly the region where the anorectal junction is present and where the puporectalis muscle encircles the anal region, right? The anorectal junction. They tell you are feeling a ridge of tissue or ridge, posterolateral ridge, meaning you feel it in this direction, in this direction, in this direction, in this direction, but not anterior. Anteriorly, no ridge, but posterolaterally, you are feeling a ridge. What's this ridge? So this is an indirect question about puporectalis. This is puporectalis. Common question in the exam, this one, okay? All right, now what about the nerve supply? Let's first talk about coccygeus, then we talk about nerve supply as a whole to the pelvic floor. Coccygeus is this one. It contributes to the pelvic floor, but posteriorly, okay? Posteriorly. It's triangular in shape, as you can see, the apex of which is the origin from the ischial spine, okay? Well, it comes to originate from ischial spine and then descend and insert onto the lateral margin of coccyx and also lateral margin of sacrum. So very simple, unique muscle. It just originates from ischial spine and insert on the back into the lateral border of coccyx and adjacent sacrum. The function, again, it contributes to the formation of the pelvic floor, and it supports the pelvic viscera, and also it can pull the coccyx forward. Pulling the coccyx forward happens during the defecation reflex. The coccyx move a little bit anterior, and it's a part of the defecation reflex. It helps with defecation. So yes, if they tell you in the exam, coccygeus, does it help with defecation? Yeah, definitely, because it pulls the coccyx forward, especially after the defecation, okay? Immediately after, I mean. All right, so what about the innervation to the pelvic floor muscles? Nerve supply wise, guys, it receives nerve fibers from pudendal nerve. Although I know that there are some studies you can see in PubMed and the American Journal of Obstetrics and Gynecology, and some of these big studies, they tell you the pudendal nerve does not supply the levator ani muscle. And in other series, they tell you it does supply, or whatever. But in textbooks, anatomy textbooks, and for the level of our exam, it does, okay? But the main contribution actually, especially to the levator ani muscle, is direct branch that is coming from anterior rami of S4. It's a nerve on its own that just comes out from the anterior ramus of S4. This is I will draw the nerve here. This is the fourth sacral nerve, anterior ramus. There's just a little nerve which comes over down from S4 and supply the levator ani muscle, okay? Now this nerve is simply called nerve to levator ani, and it is from S4. There is also contribution from the pudendal nerve, that is, which brings in fibers from S2 to S4, right? Pudendal nerve root value is S2 to S4. So it also brings in some fibers from there. Now, the key thing is that in the exam, they commonly love to ask about this question. Which of the following nerve root values supplies the pelvic floor? Is it S1, S2, S3, or S4? Remember, the main contributor is S4. You can remember it as S4 supplies the floor. S4 supplies the floor. Coccygeus is also S4 with some contribution from S3. Okay? So as a whole, it's S4. As a whole, it is S4. So we're done with the pelvic floor muscles, and we talked so much about it. Now what I want to talk about is in more detail about the deep perineal pouch and the perineal membrane. For that, I think it is better to draw a diagram. So I'll be drawing a simple diagram for you guys to simplify the picture. Perineal membrane, we already agreed what it is, right? So we know that this is the pubic symphysis, and we know that those are the bodies of the pubis. From them is the inferior pubic ramus, and that meets the ischial tuberosity and the inferior the ramus of the ischium. Also same thing from outside. This is ischial tuberosity. And then we said on the back we have the ligaments, sacrotuberous, so from the other side. And then in the very end we have the coccyx. Is that right? Margins of pelvic outlet. And then we said there is a membrane over here which stretches from one ischial tuberosity to the other, and it's attached all around this region. But this tough membrane, it has a tiny gap in front, right, for passage of structures. This gap is between it and the pubis, specifically between it and the inferior pubic ligament. There's a tiny ligament which spans here called inferior pubic ligament. There's also superior pubic ligament. So it's between it and the inferior pubic ligament. And as I told you, in the male there is a gap, one gap, and in the female there are two gaps in the membrane. So if we're talking about male pelvis, we'll just draw one simple gap for passage of membranous urethra. And on the back here we have the anus, right? So we say this is the front part, we call it urogenital triangle. Urogenital triangle. And on the back we have the anal triangle. We also said that they are not in the same level, right? The urogenital faces the ground, the anal triangle faces the back. Now, what's sitting on top of all of that? The levator ani, right? The levator ani, especially the U-shaped gap that I told you about, is attached along this margin of the perineal membrane. Is attached along this margin to the perineal membrane, the urogenital hiatus of the levator ani, or the U-shaped gap. Now the thing is that the space which is between the levator ani and the perineal membrane is called deep perineal pouch. So when we draw the perineal membrane, I'm going to draw it here. This is the perineal membrane as you are viewing it from the side. All right. This is side view of the perineal membrane. You get me? It's side view. And this is the line of attachment of the levator ani muscle, U-shaped gap. And this is the hole for the urethra. Okay. This space is deep perineal pouch. You get me? Space between perineal membrane and levator ani. This space is deep perineal pouch. This space outside is superficial perineal pouch. Okay? Okay. Now, what are the contents? What does this space, why this space is important? What does it contain? This space is so important. Very important. Why it's very important? It contains important muscles. Okay? There's a group of muscles in this space which surround the urethra, and it's the external urethral sphincter. Okay? Circular muscle that surrounds it. So that's one muscle, external urethral sphincter. External urethral sphincter. And you know, our males, we are very simple. We only have this one and an additional group of muscles which are simply called deep transverse perineal muscles, which are simply muscles like this. A sheet of muscle which fills the deep perineal pouch. That's it. That's what we have as male, right? Those are the muscles contained within just the external urethral sphincter and the deep transverse perineal muscles. In the females, there are two additional muscles. Okay? In the females, I don't have to remind you that there is also another hole over here. right, for the vagina. Vagina passes through here. Now, in the female, there are two additional muscles. There's a muscle, I'm going to give it slightly different color, which surround the urethra and vagina as a unit. You get me? There's a muscle which hugs the urethra and vagina as a unit called the uretrovaginalis muscle. Uretrovaginalis muscle. Okay? And there are two additional muscles which come from the side and encircles the anterior portion of the urethra. This is called compressor urethrae. These are not present in the male. So in the female, they have two additional muscles. A muscle which surrounds the urethra and vagina as a unit, which is called uretrovaginalis, and a muscle which comes from the sides and make a sling in front of the urethra called compressor urethrae. Okay, called compressor urethrae. Now, there's a very important structure at the back here. Let's come back to the previous diagram. There's a very important structure, a dense connective tissue lump attached to the posterior free border of the perineal membrane, and also attached here to the external anal sphincter. It's like, you know, when ships wants to travel somewhere and then they want to settle, they throw in an anchor, right? And that is exactly what it is. It anchors all of these muscles in place. It anchors its very important supportive structure to the perineal structures. So it is anchored from behind to the anal sphincter and anchored in front to the perineal membrane and the muscles in the perineal pouch, right? Including the external urethral sphincter, including the compressor the uretrovaginalis muscle. Okay, so many muscles, even in the superficial perineal pouch that we'll talk about later, is also attached to this structure, the perineal body. Okay. All right. So about the details of these muscles as origin and insertion, they're not very important for the exam, I think, but I'm just going to say them for completion. Okay. The external urethral sphincter, let's begin with this one first. External urethral sphincter. The origin, some part of it, actually you cannot see it in this diagram, but some part of it originates from the inferior pubic ramus on either side. Okay. And then it blends in a circular fashion around the external urethral sphincter, especially the membranous part of the urethra. The nerve supply, all of them, all the muscles in the deep perineal pouch, I'm going to say it once and then not repeat it again, is the perineal branches of the pudendal nerve, that is from S2 to S4. The deep transverse perineal muscles, which are those, they originate from the ischial ramus, medial aspect of ischial ramus, which is, so it comes here, originate from this, right? Those are the deep transverse perineal muscles, also from this, right? Like that, from both sides, and then they meet each other on the back. And then also behind, they are attached to the perineal body, or anchored to the perineal body. That's considered their insertion. Compressor urethrae, also from the ischiopubic rami, like this, and like this. That's their origin, from the ischiopubic rami. And how they insert into one another. They blend with each other in front of the urethra. The sphincter uretrovaginalis, the one in the females, it originates from the perineal body, right? Then encircles everything and comes back. Okay, of course, they are considered two. So one on either side, originating from the perineal body, moving anteriorly. Okay, they blend with the vagina and the urethra, anterior part of the urethra. And that will be it. That the insertion is that they blend with the other side. So origin is from the perineal body and insertion they blend from the other side. But again, I think the specifics of them are not asked in exam. You just have to know them by name, and you have to know that they are a content of the deep perineal pouch. Deep perineal pouch contains more. It contains nerves, it contains vessels, perineal arteries and perineal nerves, and it contains parts. Of course, it will contain the urethra and part of the vagina, especially the membranous urethra and part of the vagina. It also contains some glands. I will not confuse you now, but they love that in the exam they ask about it, but I will keep it later when we talk about the viscera. Okay? So this is it about this lecture. I hope you've enjoyed it, and I will see you in the next lecture. Thank you so much for listening, and best of luck.